We are very delighted to have with us today Dr. Georgiana Constantinescu from Carl Gustav Carus Hospital in Dresden, Germany. Many of you have probably read a lot of Dr. Georgiana's work, focusing on diagnostic approaches for adrenal hypertension. She has written and worked a lot on both pheochromocytomas and primary aldosteronism over the years. And today's talk will be centered mainly on using plasma steroidomics for diagnosis of PA. We are currently 5 minutes over time, so don't rush. I think it's perfectly fine. I think we're doing very good with time. So we really like to hear you. And thank you so much, Georgiana, who's joining us at 3 a.m. on her side. Thank you.
Good morning, everyone, and thank you very much for inviting me. It's a real pleasure and honor to be here with you today. So as you have heard, I've done my PhD in Dresden and worked for several years, and I'm really excited to share with you some of the results. My objectives today would be to show you what's the clinical importance of the steroid profiling and how can we interpret the results using some clinical scenarios. And I will end with a message to take home. So my first question to you would be, how often do you screen hypertensive patients for PA? You just have to take a photo of the QR code and choose one of the options. So do you always, when you see a hypertensive patient, do you suspect them for having PA? Do you frequently do this, or do you rarely do this? You just have to be honest. You don't have to put always on it. We want to know what is the normalcy for you, because we also encounter a lot of problems in Germany and other European countries. And the idea would be to raise a little bit more awareness towards diagnosing PA and see if we can improve this in the future. Okay. So I'm going to leave 2 more seconds. We can see that most of us are not doing it in all of the hypertensive patients as we would wish, and hopefully as the new guidelines would recommend it to do. But this looks pretty amazing that many of you are frequently doing it. That's so great news. Good. Thank you very much. I am now going to show you that it is indeed underdiagnosed PA, as Professor Young has previously showed us. And it is often due to the fact that primary care centers are taking care of the patients that have a resistant hypertension, the more severe cases, and all of the other endocrinologists and the general practitioners that see a lot of patients are actually, due to the lack of the awareness and difficulties of the diagnosis, are not doing it. So we only see the tip of the iceberg. The fact is that, unfortunately, PA diagnosis looks for most endocrinologists like this Romanian road, which is pretty windy, pretty tricky, and difficult to cross over. And they are demotivated because of all the different steps that they have to do. It is really important, as you have previously heard, to diagnose these patients, because they can either have a surgically curable PA, or they can go under treatment with mineralocorticoid receptor antagonists, which will definitely not only improve their aldosterone concentrate, that they will improve the hypertension, reduce increase the renin, and reduce all the cardiovascular complications that we know that PA can lead to. So we know that most of the adenomas, they harbor somatic mutations. And one of the most frequent somatic mutation is in the KCNG5 channel. And this KCNG5 channel mutation is associated with really increased concentration of hybrid steroids, which are 18-hydroxycortisol and 18-oxocortisol. And there are patients that have such an increase of this hybrid steroids that can be even 20-fold higher than the patients that do not harbor this mutation. And there are many techniques available. We combined actually liquid chromatography-based steroid profiling together with machine learning, and we used the platform to introduce all of this patient data called REDCap, and we integrated to help improve the diagnosis. So what is this steroid profiling machine learning based. This is an example of it. It has the advantage, the LCMS, and it has been used by many of you, that it can measure multiple analytes at once. And it has already proved to be useful in also differentiating different forms of Cushing and separating different forms of hypertension. Machine learning, it has the advantage of analyzing multidimensional data. It goes beyond just measuring data. It helps recognizing different patterns, and it identifies new relationships. And this is with the help of computational algorithm. And here on the right side, you can see a published paper by my supervisor, where they, together with statisticians and bioinformatics, have developed different models in order to identify patients that have this increased hybrid steroids in combination with other glucocorticoids or mineralocorticoids. So this is a very complex process. It needs, of course, to have a really good data that we can rely on it. That means that the data needs to be normalized, been taken care of batch correction. Any confounding factors need to be adjusted. And then there's a training phase where the features that are selected, namely this combination of different steroids, are cross-validated into different combinations. And then there's the predictive model that has been released with the selected features. And the third phase would be to validate this and apply it on a different cohort of patients. And I'm going to start by showing this on a couple of interesting patients. So this is a female patient. She had been hypertensive for more than 20 years. Her 24-hour blood pressure monitoring showed that she was not well controlled. She had a sodium of 141, and you can see the potassium was on the lower side, normal renal function. And she also had an antihypertensive therapy that comprised 4 antihypertensive drugs. What we usually do in Germany is we switch medication when this is possible. And in this patient, under non-interfering medication, the renin was suppressed and the ratio was positive. So you could already suspect and have a high intuition that it would be PA in this case. So this patient was enrolled in this study that's called ProSaldo. This is a prospective study, and this has exactly this idea to look if these stero profiles, they are genotype specific in this APAS, and can we in the future use the stero profile to identify the patients that are having PA due to KCNG5 mutations. So this international trial had really big expectations. Of course, during COVID, we had some dropouts, and finally there were 6 final recruitment centers, most of them European, but we also have Australian centers. And we started in 2019, and until last year, we enrolled more than 844 patients. We also did an outcome in these patients, and what this means, the normal diagnostic steps in patients that are suspicious of PA, you do the aldosterone-renin ratio, and these patients that underwent under our study, they also had this stero profile measured. And in the screening phase, it was not only the ratio that was telling us, okay, you have to go to the further step, namely to the confirmation, it was also an abnormal stero profile. So even if the ratio was normal, if you had a pathological stero profile, you would still go to a saline infusion test. This is what was mostly used in the different centers, but we also had one center that was doing a captopril. Further on in the other subtyping phase, the patients also had a stero profiling after the therapeutic intervention, which was either an adrenalectomy in the case of patients that had an unilateral disease, or therapy with mineralocorticoid receptor antagonists. The patient came to a follow-up, and this follow-up was 6 months after either adrenalectomy or therapy with drugs, or 1 year later, but it had to be at least 6 months later. So this was an important aspect of the study. The patients were followed up after either therapeutic intervention. So this is a steroid profile in this patient. You can see in the upper side, you have some information about the patient, her age. And here you can see the different steroids, the mineralocorticoids, glucocorticoids, and the androgens. And it's highlighted with yellow everything that's above the upper cutoff, and what's below it should be in blue. And we also identify this way patients that had adrenal insufficiency that we would not expect, or congenital adrenal hyperplasia, or even ACC. So I am now only focusing on PA, but this is also a useful tool for other diagnostic. On the lower side, you can see the probabilities of having either primary hypertension or PA, bilateral or unilateral, using the 3 different models. We do mean of the different models, and once it's over 50%, this means that there's a high probability. And in this patient, the mean was almost 80%. She underwent a soul loading test, and you can see here are the baseline values that were increased, and 4 hours later, the values were even higher in this patient. So the cell line showed no suppression, and we confirmed PA. The AVS was performed in this case. The patient had also an adrenal mass, and it was localized on the right side. The AVS was successful. There was selectivity on both adrenal, left and right adrenal veins, and it lateralized towards the side where the mass was present, namely on the right adrenal. And you can see the patient also had the contralateral suppression, and the patient was finally cured. She had an adrenalectomy that confirmed the KCNG5 mutation, and using the PASO criteria, there was both a clinical and biochemical cure. And this was something surprising, because you would expect in somebody that had hypertension for more than 20 years, maybe they would still have high blood pressure, but she was really happy and could not believe the results of the surgery. I will now go to a second case, which is a little bit more challenging. So this time it's a male. He is also hypertensive, he's also hypokalemic, and has an incidentaloma. So probably your clinical flare will say already that it's a high suspicion of PA. He had high blood pressure in the office, he was slightly overweight, a normal renal function, and a potassium that was again on the lower side. And what was really surprising was that his treatment incorporated a high dosage of spironolactone. He also had calcium channel blocker, lercanidipine, and potassium supplementation. So we were really mesmerized by this combination and potassium supplementation. The patient was hospitalized in NHO because of nasal bleeding, because he had a consistent high blood pressure. So he had this medication. We measured the aldosterone and the renin with interfering medication. You can see the aldosterone is high, but his renin is not suppressed. And the ratio using the cutoffs that we have was just underneath the normal side. So my question to you would be, in this case, in this patient, would you switch to non-interfering medication, or would you not do this? What would be your feeling? Okay, great. It's indeed a difficult, complicated case. He has high dosage of spironolactone, blood pressure still not well controlled, potassium not well controlled despite spironolactone and potassium supplementation, but renin is not suppressed. You would say, okay, if renin was suppressed with all of it, it's pretty sure it's PA. We don't need any further medical changes. But yes, great. So most of you would say you would still change the medication. Thanks, great. This is also what we did. We adjusted because we were not sure. So we put him on verapamil, we raised the dosage of verapamil, we supplemented a little bit more with potassium, and we monitorized, of course, the patient really correctly and regularly, and you can see the aldosterone concentration really raised. It doubled actually, and renin was very suppressed, and he had a phenomenal high aldosterone renin ratio. Good. My next question would be, what would be your next diagnostic step? So we have a lot of clinical data. He has a mass on the adrenal. He is hypokalemic. He is answering well on the spironolactone, but meaning that the renin has raised, but his blood pressure is still not well controlled. Would you do further testings to diagnose him, or would you proceed maybe to therapy? Okay, so you would agree that there's need for further testing, even if we know he had an adrenal mass, it was an incidentalloma, and there's also some of you would say go to confirmatory testing. And you are right, when patients are really hypokalemic and have really high aldosterone and are at risk, sometimes the confirmatory testing can be skipped and patients could go directly to imaging and further on if surgery is wished to adrenal venous sampling. So this patient was also enrolled in this study called PROSALDO, and in this study we perform confirmatory testings in all patients that, of course, agreed to participate in the study. And you can see here the aldosterone concentration was not only non-suppressed, but it also raised even higher after giving saline infusion. And the CT scan showed the left adrenal mass that was 10 Housefield units. It was pretty large for PA adenoma, 2.5 centimeters. He had also underwent left adrenal sampling, and it lateralized, of course, to the side of the mass with a really high lateralization index, and he also had the contralateral suppression. He had a left adrenal APA, the histology that was again KCNG5 positive. And luckily, there was also in his case a biochemical and clinical cure. The patient also had steroid profiling with under the interfering medication in the beginning and without interfering medication. And I've only put a snippet out of the mineralocorticoid here. Here you can see that his aldosterone with interfering medication, he was on the lower percentile of the normal, but his hybrid steroids were really increased, at least 6 for higher with the 18-hydroxy. And the machine learning results show the mean probability of 98%, which is really high. When we switch the drugs, you see the aldosterone increased, hybrid steroids also increased, and also 11-deoxycortisone increased. And the mean probability raised higher to almost 100%. Even some of the models showed it that it was 100% probability. So this led us to the question that maybe in some patients we should, or we could skip changing the medication and we could perform the steroid profiling under non-interfering medication. So one of the hypotheses that we had when we started the study is maybe interfering medication has a minimal impact on the steroid profiling, while on the ARR, we know it has a larger. So we looked at 800 patients, more than 800 patients that we enrolled at that point. There were no different in terms of the age and the systolic blood pressure, diastolic, heart rate between the two groups. We had a little bit more males in the PA group. Of course, the biochemical testing showed differences between the two groups. The patients that had PA had, of course, increased aldosterone and hybrid steroids, and a higher probability score than the patients without PA, as well as a suppressed renin and a positive aldosterone-renin ratio. So the patients with PA were diagnosed with PA. The ones that had adrenalectomy, we took a look at the surgical outcome, the immunohistochemical findings, and the patients that were under treatment. The diagnosis was based on the screening, means the positive ratio, positive steroid profiling, the positive confirmatory testing, and we also looked at the outcome assessment. Again, the diagnosis was supported. So we analyzed using different methods, paired and multivariable analysis, and we looked at the ROC curves between the two groups. And the problem is with patients at PA is when we have them under drugs is that especially if they're on mineralocorticoid receptor antagonists, that we might miss them, that the ratio might be negative, we miss them, and then we say, okay, they don't have PA, such as it was in the beginning, the ratio was just underneath because the renin was not suppressed, and we say, okay, it's not PA, and we go away from the case. And this is what we looked in our patients. So these are patients that were with mineralocorticoid receptor antagonists as their drug before, and then we stopped it and we measured again and we performed again the diagnosis. And when we looked, there were 33% of patients that had this decreased ratio. And this was also present in patients that were under ACE inhibitor or IRBs. And with IRBs, you can see that there was an IRR that was really low and then increased up to 500 picomoles, which means really high. So the difference can be really large in some of these patients. In patients with PA, the treatment with MRA, of course, as you would expect, had led to a decreased aldosterone-renin ratio due to the increase of renin concentration. And this was supported both by multivariable and by this paired analysis. So our suggestion would be, if renin is not suppressed from the beginning under spironolactone and it really screams and shouts, okay, is PA, to try to adjust the medication and stop the MRA for 4 to 6 weeks, and then test the patients again. ACE inhibitors in patients with PA also led to a decreased aldosterone-renin ratio, while the steroid profiling was not affected by this. Renin again was increased, and the multivariable analysis showed also an increase in renin, a reduction of aldosterone, and a minimum effect on the steroid profiling. The results were also similar for angiotensin receptor blockers. So the idea would be, after looking at the different type of analysis, multivariable and paired analysis, that actually in patients with PA, the different type of drugs, the beta blocker, the dihydropyridine calcium channel blockers, diuretics, they would not have a significant impact. So you can test the patients with PA under these drugs. In patients without PA, you would expect a false positive aldosterone-renin ratio, mostly because of the beta adrenal receptor blocker that is suppressing the production of renin. And you can see here, indeed, that the renin was suppressed in the patients and the ARR was increased. And treatment with mineralocorticoid receptor antagonists in patients that do not have PA led actually to increased hybrid steroids and increased steroid profiling. So in these patients, the steroid profiling could be falsely positive and tell you, okay, the patient has a high probability to have PA when actually they do not have PA. Otherwise, and the aldosterone-renin ratio was not significantly altered. So we looked using ROC curves. Here you have a ROC curve of the aldosterone-renin ratio in patients that were not having interfering medication, and here are with interfering medication. And you can see performed better. There's a larger area under the curve when the drugs are switched compared to the medication that is interfering. When we looked at the steroid probability scores, you can see here that there was actually not a significant difference, but still there was a slight one, not statistically important. And when we compared the two of them, the steroid profiling with aldosterone-renin ratio in patients that were under interfering medication, so no change in drugs, you can see the steroid profile is working better and has a better area under the curve. So the idea would be that this steroid profiling is promising. It's a complementary tool. It can help improve the diagnosis for the moment, only to differentiate and to identify the patients that have unilateral adenoma that harbor a KCNG5 mutation. So they're not capable to identify the patients with bilateral hyperplasia. It is also important to integrate this with clinical and biochemical findings and imaging to ensure a good diagnosis. Of course, it has a limited availability for the moment, and it needs to be validated in further randomized clinical trials. And behind these studies are many, many people from all different the world. So thank you very much, and I'm here for any questions.
Thank you very much, Georgiana. We do have some questions for you. Let's see, our measurements of hybrid hormone clinical practice in Germany, and I think what's really exciting is that your data shows that those with KCNG5s have very high hybrid hormones. So the follow-on question to that is, can patients skip ABS with high results of hybrid hormones?
Actually, in our clinics, we are bringing it now to the routine care, this steroid profile, with for also patients that are suspicion of adrenal hyperplasia or ACC, or for other adrenal disorders, it would be available, the entire measurements. And I know in France, in Paris, they're doing it also on the routine care. It's unfortunately only dedicated to highly specialized clinics, university hospitals. We have patients or doctors that are sending samples to our center in order to perform these steroid profiles. So it started to come into the routine care, but it's not status quo, no.
Okay. So people do actually go for surgery without ABS?
Yes, this is what we noticed in our center. Also, we encountered some problems with our radiology department because we had really low rates of successful AVSs, and the patients wanted to undergo surgery, and it was difficult to perform another AVS to another center because also the large distances. And we often be based on the steroid profile, the imaging is on the steroid profile, or either on the routine care. But since now everything that involves machine learning needs special improvements, and in Europe the regulatory issues are very strict, we are now undergoing the entire process to have the steroid profiling accepted as a diagnostic tool at the global level. Yeah. Yes.
Thank you, thank you. I think it's something that we'll all be very excited here in Southeast Asia, because ABS is not so readily available, and if we can get the measurements, that'd be good. Are hybrid hormone levels affected by medications?
There are to some extent affected. What we noticed is indeed when we performed the entire process, the machine learning steroid analysis, there was less influence on medication than when we looked only at the hybrid steroids. But we developed also a filling for these patients, and to be honest, when they have increased hybrid steroids, there is a very high probability that they have PA. So you would not necessarily need the entire machine learning diagnostic. It would also be useful to have the increased hybrid steroids. And indeed, these patients have also this very frost PA, the ones with the KCNG5 mutations that are hypokalemic, with resistant hypertension, with many antihypertensive drugs that are not well responding. So for these patients, but also the clinical suspicion with the imaging and the hybrid steroids would be enough to have a really high probability of a KCNG5 mutation and a curable PA.
Thank you, thank you. Again, we're all very excited because I think some studies from Dr. Tang here from Vietnam and Dr. Sarat from Thailand shows that most of the PAs in Asia are KCNJ5. So I think our patients can really benefit. And thank you very much. If there are any further questions, you can ask it to the Q&As. I'll pass it back to
I'll
you.
answer them. Thank you.